Hi, I'm Linying Zhang. I'm a PhD candidate in Dr. George Ripsack's lab. Yeah, I'm still at AMIA, so I'm calling in from the hotel Wi-Fi. If my voice cuts in and out, I apologize beforehand. So let's talk about health equity. Health equity is a very broad topic, and in this talk, we focus on equity within clinical decision-making process and specifically on treatment assignment. So many factors can potentially affect a treatment decision, such as sex, race, and patient physiology, and many other more. So how can we assess fairness of treatment allocation with using EHRs? Let's consider a specific example, coronary artery disease. Patients with coronary artery disease, CAD, are more likely to have a heart attack, myocardial infarction. There are several procedures for treating CAD together called revascularization. And so our research question is there sex discrimination in allocating revascularization resources to patients with CAD? An intuitive idea might be like this. Can we compare the proportion of men who got treated to that of women? If those two probabilities are equal, then the decision is fair. In the fairness literature, this way of defining fairness is known as statistical parity. We carried out the study and found that men were more likely to receive the treatment than women. So this fairness metric implies that there's bias against women. And however, some people may not agree. They ask, what if men were more likely to are at higher risk of having cardiovascular disease than women? In other words, this metric is not good. So in the literature, there are many ways of defining fairness. So I will show you a few more. This one is called a calibration. It uses the outcome instead of treatment and sex. It uses outcome in defining fairness. So this metric asks the question: does heart attack, the outcome happens at equal rate between men and women given their treatment status? So following this metric, we found that men had a higher rate of having a heart attack compared to women in the control group. So does this suggest that more men should be treated? And this metric gives us a different message from the previous metric. And there are more than two ways of defining fairness. This metric is called accuracy. It uses the exact same three variables as the previous metric, but arranged differently to calculate a different conditional probability. And following this metric, we found that there's bias against women. So if I put all three metrics together, what did we just learn? We learned that different fairness metrics can lead to different conclusions. And the reason why each of them is wrong can be, or not ideal, not applicable to our setting, can be complicated. But on a very high level, these metrics are all association-based, and association does not imply causation. And to be more specific, we're asking, is there a baseline difference between men and women? Does the treatment work equally well for men and women? Or is there physiological mechanisms that differ between men and women? And these are, to some degree, without proving to you, are causal questions that we. So in the next few slides, I want to convince you that fairness can be more rigorously defined using causal reasoning, and researchers are now kind of coming together to agree that causality is very important in defining fairness. So if we want to assess, maybe a better way to assess fairness is to assess fairness among patients who are similar, like patients who have similar risk of cardiovascular disease. And causality can be helpful in defining patient similarity. I'm going to show you such a fairness notion that based on causality to assess fairness among similar patients. But before I dive into that, I need to introduce a concept called potential outcomes. So potential outcomes are the outcome that would be observed if the patient receives the treatment or if the patient does not receive the treatment. So for binary treatment, yes or no, there are two potential outcomes for each patient. So if we have access to the joint potential outcomes of all the individuals in the data set, we can categorize patients into one of the 4 strata. The stable patients in the stable strata do not have heart attack regardless of having the treatment or not. Patients from the treatable strata, their heart attack can be prevented if they receive the treatment. And patients from the better without group, they somehow actually have a better outcome by not having the treatment. And patients in the severe group always have heart attack regardless of their treatment status. The important thing is that with patients within the same principal strata are considered at similar risk, that they, or in other words, they respond to the treatment in a similar way. So principle define fairness as this: a treatment satisfies principle fairness if the treatment is assigned at equal rates between men and women who would benefit equally from the treatment. In other words, among patients from the same principal strata. However, in any observational database, we do not observe the 2 potential outcomes. We only observe half of it. So we need to first be able to estimate the missing potential outcomes for all the individuals before we can carry out this fairness evaluation. So we designed a Bayesian fairness assessment algorithm to assess principal fairness. The algorithm first estimates the parameters that further can be used to estimate the potential outcomes from patient baseline characteristics, and then we condition on the potential outcomes to estimate principal fairness. So we apply principal fairness algorithm to the CAD study, and we found that in this case, across all 4 principal strata, women were less likely to receive the treatment compared to men. We also found that there is no significant difference in terms of the proportion of patients belonging to each principal strata for men and women, and also patients from the severe group had the highest, on average, has the highest probability of being treated for both men and women. So we look at this work focused on treatment as fairness, but healthcare really is a process, and bias can arise from other stages prior to treatment allocation, from diagnosis, from lab ordering, and even from access to care. So an interesting question in the future, or what I'm really working right now, is thinking about how to account for the bias that's that can arise in a different stage of healthcare process. And now also causality can be useful in different ways. For example, understanding the source of a bias. Is the bias really due to direct discrimination from the race or sex, or is it through association from social determinants of health or genetics or biology? And I think this is also a very interesting area that I'm looking into. So to summarize, I show that statistical equality often does not imply health equity, and causality is very important in fairness assessment, and accounting for bias from other stages in the healthcare process and understanding source of bias by incorporating social determinants of health information is very important in future work of health equity research. Thank you, my mentors, my collaborators, Columbia DBMI, Odyssey Network, for making phenotyping and the analysis so much easier approachable for researchers like me. And we are wrapping up the study, and we're going to have a paper on the archive soon. But if you want to get a view of the paper before that, feel free to shoot me an email. And with that, I would like to take questions.
Great, Linying. Thank you so much for that presentation. We will open it up to any questions. Again, please raise your hands if you have any questions for Linying.
Linying, this is Patrick. I appreciate your encore talk. And I'm going to ask you a adjacent question because I saw something at AMIA yesterday that made me think of your talk. Somebody was presenting that basically they observed baseline characteristic differences in utilization between race groups, and they were basically making an argument that it was inequitable simply because there is a difference in the prevalence of a condition or in a utilization of a procedure due to or difference between race groups. And in your summary here about there's statistical equity doesn't equal health equity raises a question about what does it actually mean to be a confounding factor if the causal effect you're looking at is basically like the cause of race on some factor where most of those baseline covariates would probably be considered possibly like causal intermediaries rather than precipitating confounders. So just wonder whether you could comment a little bit about the statistical challenges that we face if we really want to try to tease out a race effect where we don't want to explain too much variance because race is correlated to a whole bunch of things on the causal intermediary pathway, but at the same time we don't want to not adjust for the fact that there would be other things associated with that causal effect.
Thanks, Patrick. That's a great question. So your voice is in and out, but I think the question is how can we tease apart the causal like a confounders tease out what is let me give a maybe example. If patients are underdiagnosed for CAD, then I don't observe the diagnosis codes for, let's say, from people who members from the marginalized group, then how can I account for that underdiagnosis when I assess fairness of like treatment, like revascularization, some kind of surgery? So from a causal perspective, that we can first to estimate the counterfactual. If a patient were if she were a male, what would she receive a different diagnosis? And condition on that counterfactual diagnosis to assess what, given that counterfactual diagnosis, what would the counterfactual treatment be for this woman? So, but that raises statistical challenges because in every step doing counterfactual estimation, right? Every time when you're building a model to estimate something, there's uncertainty there. So if we really account for all the counterfactuals along the healthcare process, then I don't know how robust or how robust a method can really achieve based on the EHR data that we have. But that's a very important and interesting question that I'm looking into. So for now, for this study, I kind of assume those are the, I assume there's no underdiagnosis. For example, that whatever diagnosis code that I saw in the database reflects the true underlying conditions that the patient has.
That's great, thank you.
Linying, you got a question in the chat. What role does troponin play in your research, given there are different values, references ranges by sex with this diagnostic heart attack marker?
I have a problem opening the chat. Can you repeat the question again?
Sure.
Sorry.
What role does troponin play in your research, given there are different values, references ranges by sex with this diagnostic heart attack marker?
Right now, I use it. I encode. So for patients who have, I'm not quite sure that the medical details of troponin. So, but maybe we can talk it offline.
Yeah, I guess
right now I include as a standard concept in as it's recorded in the common data model.
Yeah, I think Linying, maybe if I were to maybe broaden the question a little bit, how should we think about laboratory measures? So like troponin's a good example where what normal means could actually be different between groups. So like a normal value for a male may actually be different than a normal value for a female, just biologically based on everything we know. So how should we think about differences in groups when in fact the measure itself may actually have a different reference as it relates to the group? Like, for example, like should we just think about how how different the measurement value is in relation to the reference. So you're either just like normal or abnormal, and account for the fact that the reference is, the reference could be gender specific or sex specific, or is there something else we should think about when the values that we're talking about really truly can be a function of the person's characteristics?
Yes, thank you for the question. And thank you, Patrick, for surfacing up the information. Yeah, I think that's a great question. I actually had a work that I did a different equity work on EGFR, because there the kind of previous medical assumptions that patients from different racial groups can have different normal, quote unquote, serum creatinine levels, and that's why they need to do this race correction in their EGFR algorithm. So that means like for patients with the same serum creatinine level, we still think that this algorithm still thinks that Black patients have a healthier kidney than non-Black patient population. So for that, I think that to me, that's a more of a biological question. What kind of evidence we have or we need to collect in order first to convince us, like doctors, that people from with different sex or different racial groups do have a different normal range for those lab measurements. And I don't see right away how we can, from observational data like EHR data, where our patients are due to access to care and all the other bias, how can we answer a kind of truly biological question from the clinical data collected from healthcare process? But that certainly this will affect all the fairness and studies we do that accounting for measurements. Yeah, I don't think I have a great answer now. I need to think about more.
Well, you brought up a good example though, that Linying, because I think currently there's even some active controversy about EGFR. Should we include the race variable as part of the calculation, which is historically EGFR has been calculated as a function of race based on your creatinine, and now people are revisiting that and asking, is that actually a biologic effect, or is there potentially some bias in there? So I think it's a really interesting and super important area to not accept some base assumptions like, well, I got a EGFR, so it must be okay, but really like questioning the merits of how was that calculated and what was it used. And there definitely could be aspects that are truly biological, but they would be separate from the bias that we're actually trying to separate. So that's an interesting and thorny problem. I appreciate you working on it.